So right now when we want to diagnose an illness and we obtain a biopsy, even from brain tissue or from heart, lung, kidney, typically a pathologist would look at microscope slides and determine whether the tissue is normal or whether there is an abnormality, and if so, what abnormality. And we know that when we send slides around to, say, 10 or 20 pathologists looking at the same slide, they will often come up with different ideas of what that tissue represents. Machine learning is now proving in practice, and this is something that has clinical applications today. Machine learning can guide the pathologists to make more accurate diagnoses. So machine learning will not take the place of a pathologist, but it will make a pathologist's time and effort much more well spent and also much more accurate.
What's important to us is to understand what mutations are predisposing you to cancers. And right now, with the latest technology in genomic sequencing, we can sequence the genome of an individual for a relatively convenient price range. So we can do that. Now the question is, how are we going to interpret this massive amounts of data? And that is the biggest challenge that we are facing right now. Which variants are pathogenic, which mutations that you're born with are going to increase your risk of cancer, and can we predict your risk of cancer based on your genomic data? Because if we can predict that, we can then suggest to you certain lifestyle changes. For example, don't smoke, exercise, all the kind of advice that we regularly give. But when you know that you have a risk mutation, then these advice changes. For example, people who are at high risk of colon cancer, if they take a daily aspirin, their risk of colon cancer decreases. And for women who are at high risk for breast cancer, based on their genetics, if they, around the age of 40, if they have serious surgery, which means double mastectomy, it's a serious surgery, but it saves their lives. So we can make these kinds of decisions.
I think while we have some technologies already, like the wearables, like the watch, I think there is further development, whether it's implantables, okay? Brain-machine interface is going to be, I think, the next step for us. We are currently looking at that and are about to do the first in-human trials for certain technologies that look at certain devices that can be sent into the brain without actually doing craniotomy. And how do we connect that to technologies, right? How do we connect that so that somebody who is paralyzed from the waist down can think about walking and then walk, okay? I think that there's a lot here left to do as far as artificial intelligence and also technologies and merging it with the human body. Other things are load prediction, for example. So a lot of teams have approached us to ask us about our expertise and determining how and if a team is too fatigued to continue and whether or not you should switch out one member for another.
Individuals who are sick, who are addicted individuals or others, they can really use this information that we could get to see how we can push them more towards recovery, a better recovery. Psychiatry, unlike other fields of medicine, has a really high relapse rate. So the disorders relapse at high frequency. For example, drug use disorder, the relapse in the first 6 months is about 70%. And we can't have that. In this day and age where we have so much data that we could come up with different biomarkers, biobehavioral markers, to really predict relapse. We still don't have that yet. But we have this data, so the outlook is good. It's just that we need help from others.